Hello everyone. In this class, we'll try to learn about abnormal ECGs. ECG is useful in detecting four types of abnormalities. Abnormal pattern of cardiac excitation resulting in different types of arrhythmias, abnormalities of myocardium, cardiac abnormalities due to alteration in plasma electrolytes, and cardiac involvement secondary to other diseases. Arrhythmia is a disorder of property of rhythmicity of heart. Dysarrhythmia is abnormalities of the rhythm, and clinical classification of cardiac arrhythmias can be bradyarrhythmias, that is, arrhythmias in which cardiac rate is decreased, tachyarrhythmias where cardiac rate is increased. The physiological classification of cardiac arrhythmias, depending on the functional site affected, they can be disorders of SA node, atrial arrhythmias, ventricular arrhythmias, and conduction disorders. Disorders of SA node. The common disorders of SA node are sinus arrhythmia, sick sinus syndrome, sinus tachycardia, and sinus bradycardia. Sinus arrhythmia is a normal physiological phenomena referred to the alteration in heart rate in respiratory cycles. Heart rate increases in inspiration and decreases in expiration, which is called as sinus arrhythmia. This is also called as respiratory sinus arrhythmia. It is explained by four mechanisms. The first one is alteration in autonomic activity. Sinus arrhythmia is mostly due to the alteration in the vagal activity during inspiration and expiration. During inspiration, vagal activity decreases and sympathetic discharge increases. Thus, heart rate increases. During expiration, vagal activity increases, that decreases the heart rate. The decrease in heart rate in expiration is due to increased vagal discharge is utilized in pranayamic breathing to improve vagal tone. Second one is activation of Bain bridge reflex. During inspiration, increased venous return to the right atrium increases heart rate. The decrease in intrathoracic pressure during inspiration increases the right atrial filling and stretches the right atrium. Thus, atrial tachycardia producing receptors are activated that produces tachycardia. Right atrial stretching also stretches SA node, which causes tachycardia. It's also because of irradiation of inspiratory center. Increased irradiation, the spillover of impulse from inspiratory center to the vasomotor center during inspiration increases the heart rate. And activation of the atrial stretch reflex, that is, increased venous return during inspiration, stimulates the type B atrial stretch receptor. This increases the heart rate. Another disease is sick sinus syndrome, where decrease in the heart rate is due to the disease of SA node. Sinus tachycardia is heart rate more than 100 beats per minute in adult, and some of the causes for sinus tachycardia are anxiety, fever, hypoxemia, thyrotoxicosis, cardiac failure, acute carditis, and drugs like atropine. Sinus bradycardia, where heart rate is less than 60 beats per minute, this occurs due to the suppression of SA node. Some of the causes for bradycardia are, can be seen in strong athletes, sick sinus syndrome, drugs like beta blockers, in obstructive jaundice, and raised intracranial pressure, and in myxedema. Atrial arrhythmias. The common atrial arrhythmias are atrial premature beats, paroxysmal supraventricular tachycardia, atrial flutter, and atrial fibrillation. Atrial premature beats occurs due to the premature discharge from ectopic atrial focus. The P wave of the premature atrial ectopic beat appears before the next sinus P wave. The configuration of the ectopic P wave is abnormal, so this is also called as atrial extrasystole. Atrial ectopics are seen in physiological conditions like anxiety, consumption of excess of tea or coffee, or in heart disease like rheumatic heart disease, coronary heart disease, cardiomyopathies, or digitalis toxicity. Paroxysmal supraventricular tachycardia, PST, it can be of two types, that is nodal PST In this condition, tachycardia, the heart rate is usually between 170 to 250 beats per minute. Occurs due to an AV nodal re-entry, which occurs due to the presence of dual AV nodal pathways. It usually occurs in paroxysm that lasts for a few minutes to hours. It is seen in normal individuals. However, it may be associated with diseases such as Wolff-Parkinson's-White syndrome, Long-Ganong-Levine syndrome, and hyperthyroidism. It is precipitated by atrial premature beats. There can be atrial tachycardia, that is atrial PST. So this occurs when an atrial focus discharges regularly. The atrial rate is usually above 200 beats per minute. It is seen in patients receiving digitalis. Atrial tachycardia may be one of the causes for paroxysmal ventricular tachycardia. Atrial flutter. The flutter wave or F wave appears in ECG, which is characterized by undulating baseline resulting in corrugated or sawtooth appearance. All impulses from atria fail to be transmitted to the ventricle. Usually, two flutter waves precede one QRS complex, so which is called as 2:1 AV block. However, 1:1, 4:1, or rarely 3:1 AV block may occur. And here, heart rate varies between 250 to 350 per minute. The atrial flutter is usually seen in coronary artery disease, mitral valve disease, rheumatic heart disease, and thyrotoxicosis. Atrial fibrillation is where atria beat rapidly but irregularly in a total disorganized way. The atria beat at a rate of 300 to 500 per minute and ventricle beats at 100 to 180 beats per minute. In ECG, the baseline is irregular and wavy due to the appearance of fibrillatory waves. QRS complexes are normal here, and it is usually seen in rheumatic heart disease, mitral valvular defect, and coronary artery disease, even in cardiomyopathies and thyrotoxicosis. It occurs due to the presence of multiple reentrant excitation wave in the atria. Coming to ventricular arrhythmias, a common ventricular arrhythmia are ventricular extrasystole, paroxysmal ventricular tachycardia, and ventricular fibrillation. Ventricular extrasystole is due to the premature discharge from a ventricular ectopic focus. The QRS complex here appears early than anticipated and looks wide, bizarre, and slurred or notched. PV is not seen as it is buried in the QRS of extrasystole. Ventricular premature beats are followed by compensatory pause. Paroxysmal ventricular tachycardia. So this occurs due to the circus movement, that is propagation of wave of excitation continuously within the closed circuit within the ventricle. The difference between PVT and PST, that is H deflection, his bundle deflection, appears in PST, but it does not appear in PVT. PVT could lead to the ventricular fibrillation. Ventricular fibrillation is due to discharge from the multiple ventricular ectopic foci or due to the presence of circus movement in the ventricle. In this circus movement, the impulses re-enter into the muscle that it had already excited earlier. The re-entry of impulses keeps stimulating the ventricle repeatedly in a circuitous manner. The ventricular rate is very high and irregular. Ventricular contraction is totally disorganized and ineffective due to rapid discharge. Ventricles look like a bag of worms. Pumping of blood by fibrillating ventricle is grossly inadequate. Therefore, circulation of blood stops. Thus, ventricular fibrillation is a medical emergency. In the absence of emergency treatment, death ensues within few minutes. Ventricular fibrillation occurs usually in patients with acute myocardial infarction that leads to sudden death. Ventricular fibrillation may lead to ventricular flutter, which appears as a sine wave in ECG with a rate between 150 to 300 per minute. So this is a diagram showing a premature atrial beat, and this is showing the paroxysmal atrial tachycardia, and these are the atrial fibrillatory waves, and this diagram showing the ventricular ectopic beat with a compensatory pause, and in the end you're seeing ventricular fibrillatory waves. Then coming to conduction disorders, conduction disorder may be conduction block or conduction acceleration. Heart blocks. It is a defect in transmission of impulses from atria to ventricles. There are three types of blocks. It can be first degree, second degree, and third degree AV blocks. The first and second degree conduction of impulses between atria and ventricles are not completely interrupted. Therefore, they are called incomplete heart block. Whereas in third degree heart block, atrioventricular conduction of impulses is completely stopped. So that is why it is called as complete heart block. First degree heart block. All the atrial impulses reach ventricle, but the conduction of impulses is slowed due to the increased delay in AV node. The PR interval is abnormally prolonged here. In second degree heart block, so this is further divided into the Mobis type 1 and Mobis type 2 blocks. In Mobis type 1, there will be prolongation of the PR interval and in a repeated sequence of beats till a QRS complex is dropped. PR interval following the dropped beat is usually normal, but in subsequent beats, PR interval progressively prolongs till the next beat is dropped. So this is also called as Wenckebach phenomena. This is usually seen in acute inferior myocardial infarction, digitalis toxicity, and acute carditis. In Mobis type 2, all atrial impulses are not conducted to the ventricles. A ventricular beat occurs every 2 or 3 atrial beats. This is usually seen in acute myocardial infarction and degenerative disease of the conducting system. In third degree heart block, where the conduction of impulses from atria to ventricle is completely interrupted. So it is called as complete heart block. The atria and ventricles, they beat separately. Atrioventricular, this is also called as atrioventricular dissociation. Therefore, in ECG, P waves that appear regularly bear no relationship with QRS complexes. The complete heart block occurs due to the disease of two locations, that is at AV node, which is called as AV nodal block, or disease of the conducting system below the AV node, so which is also called as infranodal block. Idioventricular rhythm, which occurs with a complete heart block, especially in an infranodal block, a portion of ventricular muscle becomes a pacemaker. So this is called as idioventricular rhythm. So rate is very low here. It can be as low as 15 to 40 beats per minute. The causes of complete heart block are septal myocardial infarction, His bundle injury during surgical procedure for repair of ventricular septal defects, digitalis toxicity, and degenerative disease of the conducting system. Treatment nowadays is the implantation of electronic pacemaker is the usual treatment for complete heart block. Then there can be bundle branch block. The block of either the bundle branch results in prolongation of the QRS complex. In right bundle branch block, which is called as RBBB, there will be depression of ST segment and inversion of T waves. And in left bundle branch block, which is LBBB, R wave widens with two peaks. Okay. So here, which you can see the differences between the right bundle branch block and left ventricular bundle branch block. The acceleration of conduction. The two defects of conduction acceleration, which we can see in Wpw syndrome and LGL syndrome. So, the Wpw syndrome, which is Wolff-Parkinson's-White syndrome, in addition to the three normal intranodal pathways, an aberrant pathway, that is the bundle of Kent, exists between atria and the ventricle. This abnormal pathway transmits impulses faster than the usual transmission of impulse through AV node. Therefore, ventricle excited early. The QRS complex in this premature activation merges with normal QRS so that PR interval is shortened and QRS complex is widened and slurred in its upstroke. However, uh, PJ interval is normal. The WPW syndrome predisposes to paroxysmal atrial tachycardia. LGL or Levine syndrome. So in LGL syndrome, impulses from SA node bypasses the AV node and merges with conducting pathway distal to the AV node via aberrant pathways. Therefore, PR interval shortens in the presence of normal QRS complex. PJ interval shortens due to the decreased PR interval. So here you can see this is Wolff-Parkinson syndrome and this is LGL syndrome. Myocardial abnormalities. Myocardial ischemia occurs due to the decreased blood supply to the ventricular tissue. In the ischemic region, myocardial cells partially depolarize to the lower resting membrane potential. This occurs due to the decreased gradient of potassium ion concentration. Due to the partial depolarization, a dipole is present during the TP interval in an injured myocardium due to the voltage difference between polarized, that is normal, and partially depolarized, that is the ischemic tissue. However, no dipole is present during ST segment as depolarization is complete and uniform in both normal and ischemic tissues. Thus, ST segment may be recorded as either positive or negative waves. The ST segment changes provide a major clue for the diagnosis of cardiac ischemia or cardiac ischemic injury. Myocardial infarction means acute interruption of blood supply to the myocardial results in myocardial ischemia, and if the interruption continues, acute myocardial infarction occurs. The ECG changes are very useful in the diagnosis of myocardial infarction and also to assess the location and extent of infarction. During a stage of myocardial ischemia, T wave inversion is seen in ECG. The usual changes of acute myocardial infarction are ST segment elevation in the leads overlying the infarction and ST segment depression in the leads located opposite to the infarction. Physiological basis of ECG changes in acute MI. Rapid, there is a rapid repolarization of the infarcted tissue. Within few seconds of infarction, the infarcted tissue rapidly repolarizes due to the fast opening of potassium channels. Therefore, the membrane potential of the infarcted area is higher than the membrane potential of the normal surrounding area. During the later part of the repolarization, and this makes the normal region negative to the infarcted region. As normally current flows from opposite to negative region, in acute myocardial infarction, the current flows from infarcted area to the surrounding normal areas and also towards the electrode placed on the infarcted area. This causes increased positivity between the S and T wave in ECG and it is going to result in ST elevation. The other cause is delayed depolarization of the infarcted cells. Infarcted muscle fibers, they depolarize very slowly in comparison to the surrounding normal fibers. This makes the infarcted tissue to be relatively positive to the normal tissue, especially in early part of the repolarization, and it causes ST segment elevation. Okay. So here are the ST elevation. You can see an acute myocardial infarction in different leads. Okay, so here you can see the ST segment elevation. So in the reciprocal leads, you can see the ST segment depression. Okay, so again, in AVL there is ST elevation, and in reciprocal lead, that is in AVF, there is a ST depression. Okay, and so that is how you can be able to diagnose acute myocardial infarction based on the ECG. Ventricular hypertrophy. Ventricular hypertrophies are commonly detected by assessing the deviation of the mean QRS axis of the heart and by observing the amplitude of R wave in right ventricular hypertrophy. The mean QRS vector deviates to the right and R wave is high in amplitude, about 5 mm or more than the normal in V1 lead. In left ventricular hypertrophy, the mean QRS vector deviates to left and R wave is much higher in amplitude, about 25 millimeters more than the normal in V5 and V6 leads. Okay. So this is in a normal QRS vector and V6. Okay, and in left ventricular hypertrophy, the R wave is the S wave is very prolonged, and the QRS complex is very tall in LVH, whereas the S wave is small and the QRS complex is shortened in the right ventricular hypertrophy. The ECG changes in myocarditis and cardiomyopathies. Uh, okay. So, effect of different electrolyte disturbances. Alteration in the plasma, the ECG finding depend on the concentration of the plasma. In hyperkalemia, when the plasma potassium is about 7 milliequivalents per liter, typical ECG feature will be tall and peak T waves. And if the plasma potassium levels are about 8.5 milliequivalents per liter, broadening and slurring of the QRS complex occurs and a tall and slender T wave. If it is more than 9 milliequivalents, ventricular tachycardia or ventricular fibrillation can occur. Case of hypokalemia, where plasma potassium levels about 3 milliequivalents per liter, ST segment depression and appearance of prominent U wave immediately following the T wave occurs. If it is less than 2 milliequivalents, there will be prolongation of the PR interval, ST segment depression, T wave inversion, and prominent U wave will occur. When there is altered plasma calcium level, the hypercalcemia, the ECG usually remains normal, though hypercalcemia increases the force of contraction in excess and causes calcium rigor. Rarely, QT interval is shortened. In hypocalcemia, there will be prolongation of the ST segment that causes the lengthening of QT interval. If the plasma sodium is altered, like in hypernatremia, the ECG changes are they're usually normal, except that the high voltage of ECG complex appear. In hyponatremia, there will be low voltage ECG complex are seen. So these are the effect in hyperkalemia, where you can see the tall and peaked T waves, and in severe hyperkalemia, so there can be widening of the QRS complex with slender T waves. And in hypokalemia, so there can be the prominent U waves, there can be lengthening of the PR interval, and ST segment depression and T wave inversion occurs with hypokalemia. His bundle electrogram. Recording electrical activities of his bundle is called as his bundle electrogram, and so this is compared with the ECG of standard limb leads, especially of lead 2, to determine a few electrographic intervals that help in better diagnosis of heart blocks. For this purpose, A catheter containing electrode at its tip is inserted through arm vein into the right atrium close to the tricuspid wall. The, the electrode records the His bundle electrogram. So it has a following deflections: A deflection, H deflection, and V deflection. A deflection represents activation of AV node. The deflection represents transmission of the impulses through His bundle, and V deflection represents ventricular depolarization. So there can be different intervals. PA interval. So this is the interval starting from the beginning of P wave in lead uh, to the downward deflection of A wave of HBE. So this represents the time of conduction from SA node to AV node, and normally this is 27 milliseconds. AH interval is the interval starting from A wave to the H spike of HBE. This represents the time of conduction of impulse through AV node. Normally, AH interval is 92 milliseconds. HV interval. So this is the interval starting from H spike of HV to the start of QRS complex in lead 2 of ECG. This should be better designated as HQ interval. So this represents the time of conduction of impulse through His bundle and bundle branches. Normally, HV interval is 43 milliseconds. So this is the diagram showing the different intervals, um, the A wave, H wave, and V wave, and the different intervals like AH interval, HR interval, and HV interval. So where the His bundle electrogram is compared with the lead 2 of ECG. So this is in brief about the abnormalities in the electrocardiogram. Thank you.